just to start, I just wanted to put up this graph really because this shows new cases of HIV in the Northwest from 2003 to 2012. It's represented as a proportion of new cases by route of infection. Just sort of a data definition at this early point, that when we talk about new cases throughout the presentation, it also includes transfers into the Northwest from elsewhere in the UK. And when we talk about new diagnosis, we don't necessarily mean a new infection. We know that up to 47% of adults in the UK diagnosed late with HIV. So really we're talking about a new diagnosis, but not necessarily a newly acquired infection. This picture might be quite familiar from the sort of mid to late 2000s. The number of heterosexually acquired HIV cases were predominant among new diagnoses in the Northwest. And during that time, we also saw a decline in the number of cases acquired abroad and an increase in the number of cases acquired in the UK. And to an extent, sort of treatment and prevention strategies that happened around that period reflected this change in new diagnoses. What might be slightly less familiar is that from 2010 onwards, while we were seeing an overall decline in the number of heterosexual cases, the number of cases among men who have sex with men was continuing to rise. And by 2012, they reached an all-time high, both in the UK and the Northwest, representing 52% of new diagnoses. It was this trend really that prompted this presentation. We wanted to sort of use this data to reflect and give a historical perspective on HIV and MSM in the Northwest, looking at some social, political, and also issues in practice.
I've just realised we've done exactly the same thing and not introduced which one was Hannah and which one is Jane. So I'm Hannah, this is Jane. Sorry, we should have started with that. So I'm going to talk through some of the kind of historical perspective around the HIV epidemic, kind of specifically relating it to men who have sex with men, but also generally. Just to start, we're using the term men who have sex with men as it's used as a kind of general catch-all term within health literature to refer to people in relation to, it tends to relate to behaviour rather than identity because of the way people choose to identify themselves, and some people will have sex, some men who have sex with men wouldn't ever identify as gay or homosexual, so it's a kind of catch-all term. It's a bit clunky, so I apologise for that. So I'm just going to, this graph here is the Health Protection Agency UK data on the number of new diagnoses where route of infection was defined as sex between men. And from the early 80s, I've just chopped it off at the end of the 90s, just because that's where we kind of then go into Jane's presentation. As you can see, sharp increase in the early 80s, and then it kind of did level off through the late 80s and mid 90s with between 1,500 and 2,000 diagnoses a year. My section, I'm not really going to talk about numbers. This is the only graph you're going to get, so might be a bit of relief there. I'm going to talk more about the kind of context and the developments around the epidemic that then led into the Northwest surveillance. So taking a timeline as a kind of reference point for this, the very early 80s, prior to 1981, there was quite a lot of changes in culture and society, especially around the development of a gay community and the kind of identity around the gay community and fixed areas of gay communities in places like San Francisco, New York, London. And it was within these communities that medics and health professionals started noticing cases of specific pneumonias and skin cancers and things like that that were usually very rare and only seen in people with severely weakened immune systems. And it was these clusters of conditions that were highlighted the first start of the epidemic. In 1981, the Centre for Disease Control in US kind of drew attention to this in some of their weekly reports, and it was noted in the UK later that year. Originally, it was called the Gay-Related Immune Deficiency, and that's changed within a couple of years, and realised it was more widespread than that. In 1982, some surveillance started in the UK, specifically picking up on these conditions that were rare, that kind of prompted the identification, the pneumonia and KS, which is the skin condition. 1984 was quite a landmark year with a lot of developments happening around the HIV epidemic. The discovery of the actual virus itself, the isolation of that, and the identification of it as a causative agent for AIDS was very important that year. There was also the development of the antibody test for HIV. And just very briefly, when HIV testing, and it tests for the antibody rather than the actual virus itself. And by that we mean you don't test for the virus, you test for the body's immune reaction to the virus in the body and the body's attempt to fight off the virus. The prevalence studies this antibody test allowed for prevalence studies and much more testing of widespread testing at the time. And it was also about this time that the UK media started covering the epidemic with really emotive language, and some of the headlines and around it are really interesting from the time. I'll come back to the media in a bit. Using the newly developed HIV antibody tests, studies showed that prevalence among gay men in London GUMs was as high as 35% of those people who were coming forward to be tested, and outside of London it was 11%. Interestingly, the UK didn't seem to see the same kind of rapid increase in HIV cases as they did in the US, and I think the thoughts around this is that the changes in behaviour happened earlier on in the epidemic in the UK than they did in the US, so people reduced the number of partners before the epidemic really caught hold quite as much as it did in the US. And then here we've got a picture of Rock Hudson. Rock Hudson was the first high-profile death associated with AIDS, and it was quite an interesting one because I think it really challenged people's perceptions of gay and bisexual men and the kind of macho image and heterosexuality, and it got people talking about homosexuality. It got kind of Middle England discussing homosexuality. 87 to 88, I'm just going to briefly touch on health promotion. You might remember these adverts if you're of a certain age. This was the first major government-sponsored AIDS awareness campaign, and it aimed to make people aware that the disease was a threat to everybody, was what they were aiming to communicate, not just the small groups who'd already been affected. It was, I'm sure you're probably aware, a really controversial campaign. It aimed to raise awareness, but for a lot of people, they felt that it led to a culture of fear and increased stigma associated with the condition. But interestingly, people do still talk about this now. When we do work and health promotion comes up, people still do go, yeah, the AIDS tombstone and things. So it really stuck in people's minds, whether or not it was a good thing. There was also a campaign with leaflets to every household and TV programming. Some recent research around the role of fear in HIV prevention conducted by Sigma has found that although this kind of fear-arousing imagery attracts attention and people remember it, it only really works and it's only really persuasive for individuals who are already engaging in the kind of desired health protective behaviour. And arousing fear in a lot of people can have unintended consequences. So it can lead to denial, it can lead to othering, and maybe people thinking, oh, that doesn't happen to me, that happens to other people. And actually, for most homosexually active men, was the phrase they use, are already fearful of HIV, so kind of enlisting more fear isn't necessarily going to affect and change behaviour. In 1988 as well, the Local Government Act came in, which included the infamous Section 28, and this prevented any education in schools that mentioned homosexuality. And this had an impact on sex education, on HIV awareness and safer sex and things like that, and how that was taught in schools. In the late 80s, there was calls for some sort of surveillance system that could measure, that could identify HIV levels at a population level, not just in those people who were coming forward to get tested. And the proposed unlinked anonymous system aimed to kind of increase the information people had about prevalence in the wider population. It wanted to provide predictions about the epidemic and also target prevention campaigns at specific groups. This was rolled out in 1990, and the way, just really briefly, the way this surveillance system works, they test residual blood samples from routine syphilis screening at specific GUMs around the country, and the blood samples have the identifiers, so any patient names, date of birth, anything like that is irreversibly taken off the data. I forgot to say at the end of that one. At this time as well, the AZT, the first line drug treatment with licence for use in the UK as well. Early 90s, the media and the portrayal of HIV and the epidemic in the media was beginning to become much more widespread and much more common. Just some pictures here, obviously, Freddie Mercury, his death in 1991. Philadelphia came out at this time, and it was the first mainstream Hollywood film to acknowledge HIV and AIDS, to talk about homosexuality and to talk about homophobia. At the time, there was also lots of pictures of Princess Diana in the papers. She was visiting HIV services. There was pictures of her shaking hands with people, which was quite controversial at the time. And then also Mark Fowler from EastEnders, doing a presentation with pictures of EastEnders in it. He was, I think this was 1990, his character was diagnosed with HIV, and this was quite a kind of novel one for the UK media, because it showed it was a heterosexual man who was tested positive, and it kind of tried to move things away from it being the gay plague idea. In 1995, due to the increasing numbers of people living with HIV and kind of improved life expectancy and survival, there was a move to get more monitoring of who was actually in treatment and care, and the SOFID dataset, which is the Survey of Prevalent HIV Infections Diagnosed, which is not catchy at all, was introduced to monitor the number of people accessing HIV treatment through the NHS, and it's this system that kind of the Northwest system feeds into. And then very briefly, I'm aware I've rattled through 15 years of history here, so I apologise, it's been a bit quick. Very briefly, just some developments in drug therapy in the mid-90s especially, around dual therapy showing much improved outcomes over monotherapy. And then in 1996, the introduction of the highly active antiretroviral therapy, which was the triple therapy, so literally taking 3 different types of HIV drugs. And as a result of these changes in therapy, medical professionals and the kind of national monitoring systems began to report a major reduction in the death rate of people with HIV, reducing numbers of people progressing on to AIDS, and the number of deaths generally across developed countries began to reduce. And all this led to a shift in the treatment in the services from kind of palliative care to supporting people to live with HIV and kind of much more long-term support for people. At this point, I'm going to pass over to Jane. I really hope I haven't gone miles over my time. I apologise.
Thanks, Hannah. From now on, this is where the HIV monitoring system began in 1996, and at that point there were 186 new cases among MSM, and altogether there were 1,044 MSM accessing treatment and care for HIV. Over the next 5 years, the number of new cases remained fairly steady. So by the time we reached 2000, there were 188 new cases and 1,068 MSM living with HIV. At this point, access to HIV testing very much was reliant on an individual presenting at a GRM clinic and requesting a test. But from 2001, this changed with the National Strategy for HIV and Sexual Health. This recommended that all new attendees at GRM clinics should be offered a HIV test at first screen. Many clinics at this point began to introduce opt-out testing. That's continued to this day, and it saw an increase in the number of new diagnoses, particularly among men who have sex with men. Over the following years, the number of new diagnoses among men who have sex with men increased and remained high, so that by 2006, there were 385 new MSM cases in the Northwest, which was more than double the number seen in 2000. This led to some speculation and research at the time as to what was the cause of this increase in cases among men who have sex with men. Did it reflect increased testing and a reduction in the number of undiagnosed HIV, or did it represent changes in risk behaviours, and was it actually reflecting increased transmission among men who have sex with men? The debate's probably shown by these 2 papers, which were both the most cited papers on the topic around that time. They both published in Sexually Transmitted Infections in 2007. HIV testing among men who have sex with men during this period rose. So in 1998, it was 44%, and it rose to 72% in 2004. The first story, which was by Duggan and colleagues, looked at surveillance data from 1997 to 2004, and they concluded that the rise in new cases among men who have sex with men didn't reflect an increase in incidence, it simply reflected an increase in testing. However, in the Health Protection Agency's report of that year, 1 in 10 men who have sex with men were diagnosed very late with a CD4 count of less than 200 cells per millimetre. And it was estimated that 40% of men who have sex with men who left a GUM clinic untested would be HIV positive. And that suggested that there still remain barriers to accessing testing, particularly in GUM. The second paper by Dodds looked at, it was looking at HIV testing and HIV prevalence in gay bars, saunas and clubs in 3 UK cities. They found high levels of HIV prevalence and suggested that undiagnosed HIV ranged from 33% in Brighton to 44% in London. Also, most interestingly, they found that of the 117 HIV positive men who said they'd accessed a GUM clinic in the past 12 months, 28% of them were actually undiagnosed, and a further 7.1% of MSM overall remained undiagnosed and had not accessed a GUM clinic. They concluded that stigma attached to a HIV test and barriers to accessing GUM were still preventing HIV testing. Around this time also saw the introduction of the first guidelines for post-exposure prophylaxis following sexual exposure, published by the British HIV Association in 2006. This recommended a 28-day course of antiretroviral therapy following a potential exposure to HIV. It recommends that PrEP is given within 72 hours of exposure, and it recommends PrEP is prescribed for all men who have an incident of unprotected anal intercourse, including those where the partner's HIV status is unknown, and that this should also be accompanied by partner notification and HIV testing. Several concerns sort of arose on the introduction of PrEP. There were particular concerns that a focus on this kind of treatment as prevention would reduce commitment in individuals and also in government to primary prevention strategies that were already in place. There were also thoughts that it might increase high-risk sexual behaviour. Research on this topic was quite mixed, really. A study of young men in the US found that white gay men of lower education levels were more likely to report an intention to use post-exposure prophylaxis, and that was particularly high young men who had high-risk sexual behaviour or a history of injecting drug use. But conversely, a similar study in the US looking at serodiscordant couples for HIV found that their condom intentions didn't change in relation to their awareness of post-exposure prophylaxis. Some people felt that actually post-exposure prophylaxis may improve primary prevention methods because it will prompt people into acting after a close call with PrEP to reduce sexual risk behaviours. In 2008, the national guidelines for HIV testing, the most recent guidelines were published, and in some ways this reflected the change in new cases and diagnoses that we saw on that first graph, because it was very much about increasing testing across the whole population. So it had routine universal testing in specialist clinics, testing in high prevalence areas for all GP registrants and medical admissions and for all indicator conditions. But there was still a focus on high-risk groups, including all men who disclosed having sex with a man in the past 12 months and all partners of, female partners of MSM. Around the same time, the Health Protection Agency, firstly the National Institute for Clinical Excellence in 2011 produced some guidelines to increase testing among men who have sex with men. This was based in 7 areas, so it ranges from awareness and promotion to testing and HIV referral pathways, and included a range of recommendations, including assessing local health needs for men who have sex with men to inform local strategies, increasing testing and promotion in areas that facilitated sex between men, including saunas and websites, and also the use of outreach testing. And this was followed shortly afterwards by the Health Protection Agency publishing the results of their time to test pilot, the first 9 projects within that pilot. The aim of that was to expand HIV testing out of sort of routine settings into primary care, secondary care in the community, and it included several pilots that were outreach work with men who had sex with men. Generally, the results of the pilots were very positive. They found that HIV testing in the community was both feasible to staff, acceptable to individuals being tested, and also proved cost-effective with high levels of positivity. And that leads us up into 2012, when there were 386 new MSM cases in the North West, the highest level since the monitoring system began. and in total there were 3,811 men of sex with men living with HIV. This coincided with the Lancet publishing a special issue on HIV and MSM globally, which set out some sort of priorities for future research and consideration. That included comprehensive clinical care for MSM, reducing HIV-related stigma and discrimination, specific work with for HIV and MSM in black ethnic groups, and also integrated prevention strategies that combined biomedical advances with traditional behavioural interventions. And that's where the latest pre-exposure prophylaxis trial comes in. Pre-exposure prophylaxis is the concept of using antiretroviral therapy in HIV prevention by a daily dose of the drug to a HIV-negative individual. There's been 4 successful PrEP trials globally, and the first trial, which was published in 2011, was IPREX, which was in MSN in 9 cities in 6 countries, so Ecuador, Peru and Brazil, South Africa, Thailand and the United States. 2,499 men were recruited, and they were either put into a PrEP group or a placebo group. All participants were informed that they had a 50% chance of being in the placebo group, and all were given behavioural interventions and access to condoms. The trial found that PrEP provided 44% additional protection against HIV, and that has led to the first trial in the UK, which began recruiting in November 2012, with the aim of recruiting 500 MSM who had unprotected anal intercourse from GUM sites across 6 cities. They'll be assigned to 2 groups, either immediate or deferred PrEP, with all receiving the same behavioural interventions and opportunities for follow-up and testing. Surveys into this recently have found that in London, in gay commercial venues, 58% of men who had sex with men found the concept of PrEP acceptable, and a recent Sigma survey found that 2/3 of men who found PrEP acceptable preferred it to the post-exposure option. These trials have brought up some adherence issues though. In the IPREX trial, adherence was measured by the return of pills and also by self-report. However, when a small sample of men had blood tests for drug compliance, it was found that 9% of HIV-positive men had evidence of antiretroviral therapy in their blood, and 51% of HIV-negative men, suggesting that not only was there underreporting of compliance, but there was actually quite long-term non-compliance rather than just sort of sporadic stopping and taking of the pills. And those issues need to be addressed really before these trials can go forward successfully. Pre-exposure prophylaxis has also come across some other criticisms. Who will pay for it? Will it encourage promiscuous behaviour? And why won't a condom do? I think it's interesting because when I was looking into those arguments in the media, they're exactly the same arguments that were brought up in the 1960s against the birth control pill. And I think in some ways it's a case of new pill but old arguments. And I thought that was a good place to conclude really on that idea of new pill and old arguments, because what we've seen and what Hannah's presentation shows is there have been some positive improvements through this historical perspective of MSM, particularly the advances in treatment and care, which have meant that a diagnosis of HIV today is very different from those 5 men that were diagnosed on the 5th of June 1981, with a greater near-normal lifespan and far less side effects than were seen on the early drug regimes. But we are seeing a rise in new MSM cases, and this suggests that prevention isn't as effective as it could be. And I think that from this sort of reflection, even though it was brief, what it shows is the key solution to this is to combine those new treatment interventions with the traditional behavioural interventions and testing, and that's the way to achieve the best outcomes for everyone. Thank you.